What's up, everybody? We are back, and to address the elephant in the room, we're back from a hiatus, a pretty long hiatus of not having these be posted. Obviously, with me still being a PhD student, these seasons come and go, where stuff like a podcast or content creation falls to the wayside to much larger and more important things, such as, client communication, training, as well as, obviously, my scholastic duties. But in the new year, I'm hoping to get these out a lot more consistently. I have a goal of putting them out once every 2 weeks for the entire year, so you guys will be getting 26 new episodes in 2025. With that being said, I'm excited to introduce this episode where I get to sit down with somebody that I look up to a ton, being Dr. Sean Harris. Dr. Harris is a physical therapist and a gym owner in the Houston area where he does his physical therapy sessions, so his client work, and his research on low back pain out of that gym. That is a concept that I am fully in love with and something that I want to pursue in the future. So being able to have him give me a tour of the gym and then also in this episode break down a lot of his research on lower back pain from a health and powerlifting perspective was amazing. If you guys want to check out anything that Dr. Harris has to offer, whether it be his mentorships, his gym, or just talk to him in general, all of his links will be in the description below. Before we start, though, I do want to give a huge shout out to 110% for supporting both myself and the podcast. I've known Kevin Papa, the owner, for a very long time, and I don't think there's anybody that is more passionate about getting not only an effective but safe product to his customers as him. They third-party test all of their supplements, and so if you are a drug-tested athlete, I highly suggest you checking out their products. I am personally a huge fan of their sleep supplement, which is currently sold out but should be getting back pretty soon. However, if you do want to try any of their pre-workout, it is not only the most effective pre-workout that I've taken, but also probably the best tasting. So please click the link in the bio and use code ROB for a discount at checkout. Additionally, I do have some spots open for powerlifting coaching if you have been interested in working with me in the past or just want to find out a little bit more about how I run my system within Escalate. Please don't be afraid to fill out the inquiry form that you can find in the description. Without further ado, I want to welcome you guys back to the Escalate podcast. Today on the podcast, we have somebody that I've looked up to for a while now. I found out about him, a couple years ago here in Texas. Dr. Sean Harris. He's a PT, PhD here in Houston, Texas. Owns a gym. If you want to introduce yourself and give the alphabet that you might have.
Yeah.
That'd be nice.
Well, I appreciate you having me on. Yeah, so physical therapist by training. I went to grad school the first time in 2012 at Texas Women's University here in Houston. And yes, they do accept men as well. So all my friends gave me crap about that, but it's like a 90% to 10% ratio, guys to girls. So I met my wife there, so I got the last laugh on that one.
There we go.
But after physical therapy school, I went to orthopedic residency program, also in Houston with Memorial Hermann, which is like a hospital, big hospital system here in Houston. Did my orthopedic residency there, did a fellowship, which is an extra training specifically in manual therapy. So spinal manipulation, joint manipulation, mobilization, stuff like that. And with both of those comes an extra like 150 mentor hours. So that was like a big, as we'll probably talk more about in terms of mentorship. I've had some really, really great opportunities to learn from really smart people. So I spent the first 2 or 3 years of my career really investing in that. And then, as you said in the beginning, I went back to school also at TWU to get my PhD. And all of my research that I did there was on low back pain and specifically trying to determine who needs surgery and who doesn't need surgery for back pain. And then I was working with Memorial Hermann, managing all of our spine research there for a couple of years before the gym was doing well enough and I got frustrated enough with corporate America. I decided to get out on my own. So, and that kind of brings us to here where we're at today.
Yeah, so if people don't know, Sean owns Rise Gym, Rise Barbell, Rise Pickle, Rise Class, Rise IROX, anything that you can put that is a fitness
We call
above.
it Rise City. So.
There you go, Rise City. The way that I look at it is it's a much less cringe alpha land, which is awesome if you're in the Houston area.
I love that.
But no, it's really cool. He's got a main kind of general fitness gym and then pickleball courts and a full powerlifting setup. In the back in a couple warehouses that you're now expanding, which is really cool. Congratulations.
Thank you.
When you talk about low back pain, I've always heard the statistic. You can tell me whether it's true or not. Something like, I think it's like 80%, 70% of people have a herniated disc or have some sort of like disc sublimation where, you know, and you think of it as this huge catastrophic event. Somebody says, oh, I herniated my disc. It's like, oh my God, like he's not going to be able to walk. In reality,
put him in a nursing home.
In reality, it seems to be a very common thing.
Yeah, so you're exactly right. And to give you a little bit more like specifics and context with that stat is, we'll start with what percentage of people have disc injuries, and it changes per decade. In your 30s, about 40% of people that are asymptomatic, meaning they have no back pain at all, no symptoms, will have some level of disc degeneration, disc bulge, whatever the case may be. Every single decade, it increases, right? To the point where by the time you're 70 years old, there is close to 100% chance that they're going to see some level of degeneration on an image, MRI, whatever the case may be. So depending on how old you are, that could be 70%, 80%, or like I said, close to 100%. The challenge is, what I tell patients is that disc injuries are like gray hair. Sometimes it's going to happen to all of us as we get older. It's normal degenerative process. Sometimes they cause pain and sometimes they don't. We don't really know exactly who is going to have pain with a disc injury and who is not. The biggest predictor of that is there nerve compression? Because if the disc bulge, herniation, whatever, is pressing or compressing a nerve, the likelihood of you having symptoms from that compression, from that disc injury are higher. But there are a subset of the population, probably less than 5%, with disc injuries that will have just an isolated disc injury and have severe level of pain. And we're not exactly sure why, but we think there is some type of genetic component because they've done studies where they take the ground substance of the nucleus pulposus in the disc and they've linked that to inflammatory markers in the gut. And there is a higher prevalence of people that have those same inflammatory markers present in both that will have symptomatic discs. So the hard part with disc injuries is, one, most people that have them don't have any pain. Two, when you do have pain from it, the vast majority of them don't have any leg symptoms. And then a small subset of that have leg symptoms. And the challenge is that clinically, the two main ways that we diagnose disc injuries are through advanced imaging like an MRI, which, as we just talked about, most people that have them don't have pain, so then it's not very helpful. And secondly, from a clinical perspective, most clinicians use leg symptoms as a diagnostic on whether there's a disc injury or not. But that leaves out the vast majority of people that have a disc injury that is symptomatic, but no leg symptoms. And that's kind of like where a lot of the powerlifters I see get in trouble, is they have this on and off back pain or maybe some like referred pain into their QL or their glute or whatever. They don't have any leg symptoms and they have this disc injury, and now they're like, they can't figure out how to manage the load and so on. And it becomes a big challenge because you go to the doctor's office, they take an MRI, you have a disc injury. Oh yeah, like we said before, like your life is over, right? Yeah. And so it becomes, it's a very challenging thing to manage in a lot of cases. So
yeah, speaking of that, I want to bring up something that you posted. It's a thread that you posted, I don't know, June 1st, I guess. I have a screenshot of it. PSA, if you're a powerlifter who's had some chronic off on SI joint pain, it's very, very unlikely to be your SI joint, especially if you're a guy. You probably have a lower back issue.
Correct.
Can you dive into that a little bit? Because hearing that as a powerlifting coach, I've had so many clients tell me, I've got SI joint pain. I'm like, I trust you.
Yeah.
You know, I'm not a clinician. I have to give you the benefit of the doubt because I can't diagnose you. That's so not okay.
Yeah. It's funny because the motivation for posting that was because I had probably 3 or 4 clients within a week period that told me, oh, I've got an SI joint problem. And the reality is that unless you are a young pregnant female or someone who has a true like genetic ligamentous instability problem, your SI joint moves so little that it is almost impossible for that to be a problem. And specifically for men, because we have a narrower hip angle, the whole point of the SI joint is to basically transfer forces from your lower extremity up through your spine, right? That's really it's an energy transfer mechanism. And the SI joint in men moves so little and is so stable that it's not to say that that area couldn't be painful, but what it would take for it to be painful would be like a direct fall or trauma or something directly on that area that would cause some type of pain problem, right? 2, it would heal relatively predictably over several week period based off the severity of the injury. And 3, your SI joint as a young male, even if you are in that small percentage that it is what's causing your pain, it's not out of place. It hasn't shifted anywhere. It's not upslipped or anything like that. So out of the 3 or 4 that I saw that week, 2 of them had told me that another practitioner had told them, oh, your SI joint is out of place. And I was going through the whole, the hard part is I can't just immediately tell them like that's dumb, right? Because we'll talk probably more about this, but when it comes to communicating these types of things with patients, especially if the patient's bias is somewhere else, the whole goal of the interview process and really establishing care is to align yourself with the patient. Like they need to be your ally. It's all about, we call it therapeutic alliance in the healthcare world. So the challenging part is, how do I take this, let's say, misinformed opinion or bias that they have about their own body and educate them and kind of guide them into, let's say, what's correct, right? But the reality is that your SI joint moves so little, it is very unlikely to ever be problematic or painful, specifically for the average adult male population. But the distance between your SI joint and, let's say, L5S1 vertebrae, which is one of the most common discogenic injuries, is like, we're talking a couple inches. And when the disc is irritated or the joint is irritated, it will commonly refer into the SI joint region, into the glute. And on a clinical exam standpoint, it's super easy to differentiate because you can do things to stress the lower back and things to stress the SI joint, and then you see which of those are painful. But I don't know where it like caught on, but it became like a ubiquitous thing where all of powerlifting, every single person that was weightlifting, oh, I have pain when I'm squatting and deadlifting, it's my SI joint. And it seems to have solely come from the fact that they felt pain in that area. But as maybe we'll talk more about as we go through, but pain, like where it hurts, is not a very good predictor of what it actually is, if that makes sense. So I
think with the powerlifting side, and obviously they're not clinicians, so why the hell would they know these things? It's not their job. I think it also comes down to knowing anatomy, right? People think that a low back is where the bottom part of their erectors are. That's maybe like T12L1, right? When in reality, most of the low back pain that you have is where you think your SI joint is. So it's just like they're trying to figure it out, and they're like, well, it's not my erectors. So it can't be low back. So it's got to be SI joint.
Exactly.
And
it's in my glute, Well, it's like, I think part of the problem is, as a researcher yourself, the term face validity, right? It's like it makes sense if I have pain right over this area, then it would make sense that is the exact area that the problem is. Same thing, like I have lifters all the time say, oh, I've strained my QL or I strained my erector. And I know from a biomechanical standpoint, it's very, very difficult to strain an erector. But what commonly happens is when the joint or some other tissue, like ligamentous tissue, the disc, any of those supportive passive structures, they have mechanoreceptors built into all of those tissues, right? That's how we know how much pressure, how much load. And those mechanoreceptors, when it senses a problem at the disc or any of those tissues, there's a natural reflex arc between those mechanoreceptors and your erectors and your QL. So if you do something that tweaks the disc a little bit and it becomes a little bit sensitive, mechanoreceptors say, hey, there's a problem here, sends a reflex over to your muscles, hey, spasm, tighten up. The reality is that if you strained your QL or you strained your lumbar erector, you would have bruising, you would have some type of local tissue swelling. And 2, if let's say it was a really mild strain, it would go away within a couple of days. Right? If it's not bad enough to cause bruising, it would be better before you even have time to seek help. So if you're a lifter that has had off and on like QL tightness or QL strain or a lumbar strain or whatever the case is, and it's been 3, 4, 5 weeks or more, it's a joint problem. There's something, whether, when I say joint, it could be disc, ligament, any of those tissues, but it's something slower healing and more passive structure than your muscles. So.
Yeah, I like how you mentioned that, you know that it's something joint related if it goes on for a certain amount of time, and that's when you start to think that it's pretty severe, right? And I have this conversation with a lot of my friends that are coaches, I try to have this conversation with some of my clients that, tell me, I'm in pain, all that kind of stuff. I want to know your standpoint on this, because I am very much so in the camp of, obviously, as a coach, as a clinician, you need to trust somebody when they tell you that they've got pain.
Right.
But I'm in the kind of mindset where pain isn't necessarily an overall bad thing.
No.
100% of the time. And it shouldn't impede you from doing most of what you can possibly do on a day.
Yes.
Like for example, I think it was last Thursday. Mm-hmm. I went to go deadlift in the morning, and I've had chronic low back pain since I was 18. I had a catastrophic incident where a bar rolled over my back in high school. And that is where that's where I can say okay, I herniated a disc.
Something
that happened right there, because I was barely able to walk for a couple days.
Yep.
It flares off on and off, and I had a flare up. And I thought to myself, I was like, you know what? I'm just gonna wait 4 days, and I'm not really gonna. I'm just gonna keep loading what I should be loading for each of these days to stay on track. And guess what? I'm pain free right now. So
you touched on something that is vitally important, and also probably one of the biggest complexities in managing musculoskeletal pain. What I tell patients is pain is information, and it's really your body's only way of telling you that something is not in an ideal state. Think of we have to go back to our roots. What is the purpose of pain, right? The purpose of pain is to protect us from injuring ourselves. And there are actual genetic, very rare, but genetic conditions where people are born without specifically just the pain receptors and those nerve fibers, meaning they have normal touch sensation, normal hot and cold sensation, muscles, skin, everything functions normally. They just physically can't process pain. And those people have to, as a baby, have to have all their teeth pulled out, have to wear protective lenses for the rest of their life, have to wear body armor basically. Because think about how we learn to interact with our environment is extremely predicated on pain. You're a baby, you touch something sharp, you touch something hot, you pull away, it's a negative experience, therefore I'm going to avoid that. Well, as we become adults, and as we, if you're going to be doing anything where you're pushing your body physically to some capacity, the expectation that you'll never have pain is an extremely bad expectation. Our goal is always to take the information that our body is giving us by saying something hurts and try to figure out what do we need to do differently to continue training and be as active as we possibly can. And one of the interesting things is, if you look at the research from chronicity of back pain, people that tend to catastrophize, people that tend to avoid activity after those injuries have a much higher percentage of chronicity. So what that essentially means is, if something hurts and you're going to the gym and you put 450 pounds on the bar on squat and it hurts, well, okay, can I reduce my range of motion? Can I slow the tempo down? Can I change the position? Can I change the load? What can I change to get in that reasonable amount of pain? And if I can do that for a long enough period of time, not only will I keep most of my strength and function, but then it will also help in the healing reparative process, because if you listen to pain and you work around and with pain, it will help your training and it'll help prevent things from getting worse. But as you probably well know, in the it's not just powerlifting, it's really all high level sport. They get pain with something, they get frustrated, they can't train the way that they want to. Everybody has this kind of circle of life where we've got our social, that's a part of it. We've got our recreation, that's a part of it. We've got our family, we've got our work, right? Think about, let's say you are a competitive level powerlifting. Every part of your circle has to do with lifting well, right? Your social circle, they're all powerlifters. People you work with, well, let's say you work as a powerlifter, so everybody you work with, they're powerlifters, right? Your recreation, well, you enjoy lifting, that's part of it, right? Every part of your circle is affected by that injury, and then you start catastrophizing, well, I can't even do this, I get frustrated, and then this little nugget of a problem becomes this huge, big thing. And we know that when these types of issues become chronic, it's not as simple as, oh, you've got a disc injury anymore. We've got all these other layers of things, and that's true with almost all pain conditions, but the back specifically, chronic back pain, if you had to guess, how much do you think we spend on managing chronic or not, let's just say low back pain in the United States every single year? How much do you think we spend?
Monetary amount?
Monetary amount.
I gotta think it starts with a B.
Yeah.
I gotta think it starts with a B. Somewhere in the billions of dollars.
Yeah. $300 to $600 billion every year.
Oh my Lord.
And that's more than heart disease. That's more than cancer. That's more than diabetes and all that. And the reason for that is what we call direct and indirect costs. So obviously direct costs is like, pharmaceuticals cost this much, surgery costs this much, physical therapy costs this much. But when we factor in indirect costs like missed work time, disability, those kinds of things, the indirect costs are about 40% or more of the total cost, and it inflates that number like crazy. And the reason is like when you have a debilitating back problem and you have any type of, not even a physical job, but anything where you have to move around, lift, do anything, now you're on disability, right? Now they have to hire, another company has to hire someone to fill in your position. So it just becomes this huge, big problem. And the fix to most of that is opposite from what like traditional medicine says, which is, you strained your back, here's a pain medicine, here's a muscle relaxant, take some time off. When the reality and the struggle is, the research is very clear on this. If you have an acute back injury, 80% of the time in 6 weeks is going to go away. Yep. As long as you stay active, right? We don't really need to introduce any pharmaceutical medications at all, except for maybe over-the-counter anti-inflammatories at the beginning. That's it. If you start taking tramadol, opioids, other things, the chronic chronicity problems go crazy, which at least we're somewhat getting a grip on that. But people need to be educated that, okay, hey, you were in the gym, you hurt your back. Awesome. What can you do? Can you walk? Can you go work out accessories? Can you do whatever you can do with not no pain, but minimal, manageable pain, kind of how you described, like what can you do in the gym? Do that for as long as you can. And over time, you're going to be able to do more and more and more and more until you're back to normal.
Yep.
If you do nothing, when you try to randomly walk back in the gym in 2 weeks after doing nothing for 2 weeks, what you're going to find is that you can actually do less and less and less and less without pain. So my advice for most lifters when they have an acute issue like that is we screen for red flags, like make sure there's no severe nerve compression, blah, blah, blah. And then it's just all education. Hey, you're going to go for a walk. You're going to do these exercises. You're going to go in the gym. You're going to try to do, this is the parameters of pain that are acceptable. Do as much as you possibly can within that realm. And if you keep showing up, you keep staying positive, you keep listening to your body, each week you'll be able to do a little bit more, a little bit more, a little bit more. And that would fix probably 90% or more of back problems. But what ends up happening is they go to the doctor, they get a prescription, they sit on their butt, they don't want to be active. They're afraid now to be active because that's how they hurt themselves. And it just becomes this whole, multiple layers of problems.
Yeah, I mean, there's a whole portion of PT school about guarding, right? And guarding, low back pain or any sort of joint pain, where it's like as soon as they get back into, that specific activity, even though they know it's pain-free, they're still so hesitant.
Fear avoidant. It's tough.
And a strategy that I use that actually came from another one of my friends. It's a PT, Devaraj Roy, who's up at in New Jersey. He actually owns his own telehealth service now.
Oh,
he
nice.
Graduated from Rutgers. Shout out to him.
Little plug.
Yeah, little plug. He gave me a great strategy, and so for any coaches out there that need one, it's essentially just telling the client, one, obviously load manage, like with variation, right? If you're doing a low bar back squat, maybe put them on a safety bar, right? That's like something that you can automatically do. But two, if you don't have to do a variation, just say, hey, don't go above +2 of what your baseline pain level is. And in powerlifting, it's hard to figure out what baseline is because obviously you walking around, you might not feel anything. But as soon as you put, 125 kilos on the bar, that's where you start to feel something. I will tell them that is your baseline. Right. And so if that's a 3, don't go above a 5. And then if it's such a significant, reduction in load that it's not even worth doing, that's where we throw in the variation. It's like, okay, then try a safety bar squat.
100%.
And then don't go above a 5.
Yeah, I use almost an identical variation. The only slight difference is, so let's say if they have pain at rest, I use the +2. So like let's say they're just walking around, they've got a 1 or 2 out of, okay, cool. It's going to be a 4. Don't go above a 4. If they have 0 pain, I just say, hey, we're not going to go above a 4 or 5 out of 10. and we don't want any like sharp or like, you know, debilitating stabbing pain. And of course, the next thing everybody says is like, oh, well, I have a really high pain tolerance. Or like, what I always tell people is like, if I can walk by you while you're squatting and tell that you're in pain, it's too much pain, right? If I can visually see it on your face that you're in pain, it's too much. If you can hide it, if you can carry on a normal conversation, if you can pretend that it's not hurting, it's probably okay. So I kind of use that, but it's exactly the same. That's exactly what I tell people to do as well, because again, it removes the expectation that it should never hurt at all. Like, it's okay for it to hurt some. And in fact, exercising through some mild to moderate discomfort has been shown to improve symptoms better than completely avoiding pain and only doing activities that don't hurt, right? Sometimes it depends on the patient too. If I have a patient that is very easily frustrated, right? Meaning, if they were to go into the gym and try to do 315 on whatever it is, and if they can't do that, that's going to put them off in a bad mood, then what I may do is I may change it a little bit, and I may say, hey, we're going to try to limit some of that frustration. So the goal is we're going to do different things, like take you away from the squat, the deadlift, or whatever those triggering things could be. That way you have no frame of reference of what weight is like, you know, good or acceptable. And we'll do things like the leg press or some other variant until we can build up a little bit of a foundation of some kind of confidence and strength, and then we go back into it, right? So there is some variability there depending on the patient, because as I'm sure you well know, that we have some people that, like, if they can't squat 400 pounds, they don't even want to be in the gym. Like, they're embarrassed to be there, right?
I've been that person.
Yeah, exactly.
I think we've all been that
100%. And to be honest, that's what got me into trouble with my own back injury. Is I was like, I'd walk into the gym, if I saw someone else doing more weight than what I was doing, like, that would put me, like, I knew mentally, like, physically I could do that weight, but I can't right now. And that would completely set me off, right? So some of that is a little bit of maturing that needs to happen, right? But our goal and our role really as providers is to help facilitate that process. Like, give them things they can do, build their confidence, you know, walk them through that process, be that support, person for them to try to help that gym fitness maturation along. You know what I mean?
Yeah, no, that's awesome. You mentioned that you had low back pain yourself. Is that what kind of triggered your interest in research in low back pain?
Yeah, I was like, one of the classic statistics. I was in college weightlifting, felt a pop in my back, racked the weight, like was on the ground, couldn't get up for a while. I remember going home, and I remember feeling, it felt like there was like water trickling down my spine. That's what I felt. So I remember typing that into Google, and it came up with a disc injury, and I was like, oh shit, you know. And I was able to kind of like work through it a little bit on my own. Eventually I went and saw a physician. They spent, and this is not like I know a lot of really, really good physicians out there and a lot of good spine surgeons, but there's a lot of really bad PTs and a lot of bad coaches. There's some bad physicians out there. And the first person I went to spent literally 1 minute in the clinic room with me, checked my reflexes. That was it. Gave me some tramadol, told me, hey, come back in a month or so if it's not better. Well, a month goes by, it still feels the same. I go back, they referred me to a spine surgeon, took an MRI, told me I had degenerative disc disease. The surgeon also spent maybe 4 minutes with me in the clinic, told me, don't ever weightlift anymore, don't play sports. He actually spent, out of that 5 minutes, 2 minutes of that was telling me I needed to be careful putting on my shoes and socks in the future because I could re-herniate my disc, all that stuff, right? I was 21 years old, and at 21 basically told me, and at the time I was still on the rugby team, I was still weightlifting actively. My back, I was just working, through it. And I remember thinking, like, there has got to be a better way to managing this, and that's what kind of got me interested into physical therapy. And then once I got into physical therapy school, was really interested in learning more about low back pain. And then I realized that there is, even in physical therapy in the program, I graduated and I didn't feel like I was like comfortable or confident with managing low back pain. I had a lot of unanswered questions, which is what sent me down the residency and the fellowship and all that kind of stuff. And then obviously ultimately decided to research that for my PhD dissertation, because there's just so much misinformation and disinformation out there. And I was like, I just remember thinking, how many other people have been counseled this information, avoid all this activity, and how many people are actually listening to it, right? I was a kind of a stupid 21-year-old, like, I'm not going to stop doing the things that I want to do. But imagine if you weren't as invested or motivated to work out and you had a surgeon tell you, hey, it's not safe for you to lift weights anymore for the rest of your life. How many people has that dissuaded? And I've heard it from patients all the time. Oh, I don't squat anymore. Oh, I don't deadlift anymore. I injured my back. And I just want to grab them and be like, if squatting and deadlifting is not important to you, then don't do it. It's not like you have to do it. But if you want to do it and the only reason you're not is because you're worried about injuring your back, that is a problem, right?
Yeah.
That just promotes so much fragility. Like, I can't do this because my body will break or something, which, again, the research is just very clear that's not the case, right?
Yeah, no, 100%. And we had talked a little bit about your research in your office when you were giving me a tour of this place. And I know that you collaborated with a ton of powerlifters on a recent poster, and I assume paper that is in review.
Hopefully submitting like this week.
There we go. Beautiful. I don't know how much you can talk about that.
Yeah.
I don't know if you're somebody that likes to guard that data or not.
No, totally I think it's out there, and I honestly, I'd like to. The goal is to get this paper submitted and then to try to expand on it with a larger data set. But yeah, essentially in a nutshell, when you look at, so a lot of my dissertation research was looking at obviously predicting who gets surgery, who doesn't. And through that process, we looked at a lot of performance testing. So a lot of you guys, if you're powerlifters, have probably heard of like the McGill Big Three and those kinds of things for preventing low back pain and helping to treat it. And when you look at the research on pretty much any physical test for performance and whether it has any predictability for, let's say, likelihood of injuring your back, recovery, so on and so forth, there isn't a single exercise or assessment that is predictive in really any meaningful way of low back pain, whether it's prevention, injury, whatever the case may be. Now, we know that doing core exercise in addition to a bunch of other exercise can definitely help improve back pain, but it's not as simple as like, oh, your abs are weak, therefore that's why you had back pain. And that was something I heard all the time as a PT. We would tell patients all the time, like, oh, well, your plank testing is not very good. You have a weak core. That's why your back hurts. And when I looked into the data and we started looking at all the research, I realized like, well, that's not really the case. I've had plenty of powerlifters that can hold a plank for 5+ minutes, are like super diligent on their accessories, and their back still hurts. And I've had plenty of powerlifters that haven't done a crunch in their whole life and their back feels fine, right? So what I started thinking about was like, okay, all of these performance tests that we're looking at, like plank, Sorensen, side plank, all of those things are really looking at resistance to shear force, right? Like our body is in some type of linear position, gravity's pulling it down horizontally. That is not the way that our spine is loaded when we're weightlifting. It's all axial compressive forces, right? The purpose, the goal, the function of our spine when we're deadlifting and squatting is all about energy transfer, right? The weight needs to go from the force comes through our legs, up through our spine, and then transfers to the bar, the weight moves, right? So, and all of that force is axial compressive force. So I started thinking like, what could we do to better look at and assess a lifter's ability to resist axial compressive forces? And so I started thinking about how would we be able to measure how well someone could diaphragmatically brace, and so what I did was we took a traditional weightlifting belt and I rigged up a load cell on the weight belt. So they put the belt on like normal, and then what they do is when they go to brace, it measures we call it abdominal hoop stress, but it measures how much force they're able to generate outwardly into the weight belt, right? And the cool thing about it is I kind of did it as like let's just see if this will work or not. And the first time I put the belt on, like you could talk to my wife. I was like, I ran through the house. I was like, Amy, look, like I have the app on my phone. I'm bracing. You can see it go up. It worked 1,000 times better than I ever thought it would. And that's when I started realizing, like, okay, there may be something here. So long story short, we ended up kind of just tweaking the belt a little bit so it was a little bit easier to apply and use, and then recruited 25 active powerlifters that did not have a current episode of low back pain, but we screened them if they had a history of back pain. And we ended up with 13 people that had a history of back pain within the last 2 years that kept them from competing, and 12 that had no history of back pain. And we measured their ability to brace under different dynamic loads on squat and on deadlift. And what we found was the group of people that had a history of low back pain scored about 60% of what on the bracing test than what the group that did not have a history of low back pain. And when we ran it through all the prediction models, basically their ability to dynamically brace well had a really strong predictor, not only in their whether they had a likelihood of history of low back pain, but also how much weight they did, right, relative to their body weight. So all that to say is, for me now, clinically, I use that as a way to assess, and I'll look at plank testing and stuff a little bit just to get an overall sense for, like, let's say, are their lumbar extensors way weaker than their abdominal muscles, something like that. But if they have issues with axial compression, meaning like they get underneath a squat bar or a deadlift and they feel pain as soon as they add load, and it's very load dependent. And then on a clinical exam, if I can manually add compression and that reproduces their symptoms, I will put them on that bracing belt and get kind of like a baseline level of how much force they actually have. And the goal is obviously to assess it, but then now we have something that we can physically train and track to see if they're able to improve that, right? So some of the future research I like to do would be to look at a bigger data set of individuals and a symptomatic data set if possible, like people that actually have current episode of low back pain as opposed to a history of it. And then also looking to see if we track it and treat it over time, does that get better, and does that correlate with their improvement in their performance as well? So,
dude, that's fascinating. That's so cool. I use load cells in all my research. People that listen to this, kind of a lot of friends that know that most of the stuff that I do, I kind of told you about, is skill learning, but I use forces as the skill. Right. I'm telling them, or I'm teaching them how to hit targets. Right. Using certain feedback or looking at how motor unit, firing rates change throughout that, from novice to expert. Performance and stuff like that. Were you using, was it just like a Futech?
Tyndek device.
Load cell? Nice. That's super cool. And it's just placed right there in the belt?
I basically modified I took off the lever part and I modified it to where now we just use a strap. So the strap is linked into the load cell. Load cell is linked into the belt via a little metal fastener, and then you just put it on like a normal belt. You strap it on, and the way that we did it, because the hardest part is like, well, what if how tight they put the belt causes problems?
That's what I'm thinking.
What we decided to do was everybody self-selected how tight they wanted it, like so it would mimic what they would normally do in the gym, and they would just zero the cell, zero it out. So it was the great part about it is that the reliability of the testing of the numbers was way better than I thought it would be. Like you could have somebody talking and it would be able to pick up on the sensitivity, like just from them talking and that diaphragmatic pressure, you could see it move up and down. So it actually worked 1,000 times better than I thought it would. So.
And are these people that you were currently working with at the time?
So no, I basically went to U of H powerlifting and started there. And then when we had the in the gym as well, we recruited from there as well. So it was a combination of like U of H powerlifting team. They were gracious enough to let me come out there a couple times. And then the last maybe like 5 or 10 subject we recruited from the gym. Our active powerlifting. It was all collegiate powerlifters, by the way. So 18 to 25.
Yeah, I mean, that's an important demographic because that is probably around 75 to 80% of the active population of powerlifters. So it's a good representation of the population. That's really, really cool. I want to shift the conversation a little bit, if we can. You talked a lot about when, dealing with low back pain, when, going to a clinician about low back pain. You talk about feedback a ton, and I'm going to bring up something that you said again on a thread. Where you said that there's 3 levels of receiving feedback. You should be open to hearing all feedback. You should think over some of the feedback, and you should act on few of the feedback. That last one confuses me a bit, right? Because as a clinician, you're like, I'm getting all this feedback from a patient, or as a coach, you're like, I'm getting all this feedback from a client on what they think they should do to feel strong, which is like gold for us,
Yep.
right? Because we're like, if you know that this is what makes you strong, like, oh, then we've got the formula out right.
Right.
If you can dive into that a little bit, that'd be really, really cool to hear about.
Yeah. So that was kind of posted in context outside of not just with weightlifting, but in life, right? Like, too many people are heavily biased by what they are exposed to. You know, they've kind of made up their mind on certain things, and then they're unable to see new information, right? And the challenge is that we can't, for example, if we had, let's say you were to interview 10 different people on low back pain, right? And you would hear some similarities, but probably a lot of different stuff, a lot of different information. And if you were to act on every piece of new information that you got, you would be ping-ponging around like crazy. And to give a couple examples, let's say for the gym, we get feedback all the time. People want this equipment, they want this way, so on and so different music, right? It's physically impossible to act on all of those things without us changing stuff back and forth literally every single week. But we also don't want the perception of, hey, we're not listening. Because it's very easy to work in kind of black and white situations where either you're open to all feedback and then you feel like you can't do, or you're ping-ponging back and forth, or you're completely closed off to all feedback. And the reality is we want to be open. We want lenses open, receiving everything we possibly can, but we have to have some type of filter system. And some of that comes down to kind of critical appraisal, right? So what I always tell patients from a patient perspective is you have to be your own advocate for your own health. Meaning if you're going to be paying for an intervention, if you're going to be doing whatever the situation calls for, you want that to make sense to you, and you want to find a practitioner that is going to help you make it make sense, right? And that involves listening to what they have to say. That involves that second part, which is I'm going to ask some questions about that. I'm going to try to decide whether this is good information or what the case is. You ask some questions, you talk about it, and then you finally ultimately make a decision on taking an action, whether it's a surgery or intervention or whatever the case may be. And that's kind of like that filter system that is most appropriate. And it's hard because obviously, depending on the health literacy of the patient that we have, they may have really good health literacy and good ideas about what's going on with them and what they need to do, or they may have no idea at all. One of the biggest problems in our healthcare system is that people will follow the advice blindly from all types of different healthcare providers. And they just say, oh, the surgeon in front of me, I'm just going to listen to whatever they say. That's not a good practice to have. And what I always tell clinicians is we tend to see ourselves as like this superhero for the patients. Like, oh, we're going to come in, I'm going to tell you what to do, you're going to listen, I'm going to help you, I'm going to save you, fix this problem. Most patients don't need a superhero to save them. They need an Alfred to guide them, right? Like, we're not the Batman. The patient is the Batman. The patient is the star of the show, and it's our job to help facilitate that. And sometimes that's physically providing treatment, sometimes it's education, sometimes it's whatever. But when I sit down in front of a patient, and I would encourage, whether you're in patient care, whether it's with a client, the goal should be to educate and support them. And in some cases, they may even tell you like, hey, I just want you to tell me what to do and I'm going to follow it. And okay, that's fine. That could be our, agreement. But most of the time, the whole relationship works better when they're playing an active role in their recovery, in their programming, and whatever the case may be. So all that to kind of summarize, we can't be closed off to feedback because that's the way that we make improvements and we get better. We also can't act on every single piece of feedback that we get because the result is going to be, what is it, the saying, a friend to everyone is an enemy to yourself, right? So we have to have some filter system involved where we're open to everything, we're thinking critically about everything, and we're only choosing to act on certain things once the level or the threshold of information to make an actionable change has been reached. And you can apply that in healthcare and patient care and coaching and in business, right? Like if I were to act on every single piece of advice that people give me, I would have been out of business 3.5 years ago, right?
Yeah. I mean, what it sounds like to me is just that 90% of creating a positive relationship with a client or with a patient or with whoever it is comes from education.
100%.
And I want to ask you about your approach to education, because I think it's the approach to mentorship from being a coach and learning from another coach, very kind of black and white, right? You learn from them, you have a couple calls, maybe it's an online mentorship, stuff like that. And then obviously in the clinical setting or in like a PhD, you're learning from them. You spend 5, 6, 7 years with them to learn from them. When it comes to your approach of mentorship and your approach of education with somebody that may not be coming back, hopefully will not be coming back to you, that's the goal, in 8 weeks or even less than 8 weeks, what does that look like for you?
So to be a good educator, it starts with yourself, and you want to have as complete of an understanding of the problem as possible, because if we don't understand it at a variety of levels, it's very difficult to teach anybody anything, right? The other thing is, so that's the first part. So like you want to make sure that your shit is squared away, if that makes sense, first. The second one is, in order to educate others, it's all about obviously influencing them in a positive direction, and it's knowing the other person. So certain people, so I guess I didn't talk about this much, but in the residency and fellowship, I did a lot of mentoring other clinicians. That was actually a huge part of my job when I was at Memorial Hermann I would be mentoring sometimes 5+ hours a week with other clinicians. Some people need certain things. Some people need different things. I think it was like Socrates who said some need, they need a whip and others need like a rein, right? So a lot of it comes down to, okay, have I done everything that I can possibly do to be as knowledgeable and as informed as I possibly can? And then once I have I done everything I possibly can to understand the person that I'm talking to, right? What's my relationship with them? What's their prior knowledge? Where are they at and where do they need to go? And depending on all of that information, that's how the information is transferred, right? The other thing to think about too is, and this comes down to like, it's what's the person's readiness for information, right? When it comes, the way that I educate other clinicians, the way that I educate peers, the way that I educate patients is always different. It's different on what's the dynamic of our relationship, right? So as you well know, in academia, there's a lot of ego involved, right? For one PhD person to talk to another PhD person, there's this whole song and dance that has to occur and what I've realized is like, if I really want to promote change, let's say I have another clinician that I'm working with that, let's say, treats differently than me. And in my opinion, I probably think that they're maybe doing things differently than I would, and they probably think the same way about me. If my goal is to elevate the standard of care of everyone around me, the only way that happens is if I build a relationship with that clinician. Because again, if we're peers, for whatever that goes to, they're not just gonna readily be like, oh, hey, Sean, tell me about how I should treat this patient or whatever the case is. So there's gotta be a little bit of massaging of that ego that has to occur. So all that to say is that, for me, the way that I look at education has changed a lot as, now, not only am I educating patients, but I'm educating, I teach courses. I'm trying to educate and lead my team here with my businesses. Like, how do I teach them to be better individuals, better leaders, to support the company better, all of those things. But the way that I do that with every single person is different based off of the person, off the context, based off my expertise level in that area. So it's one of those things where the more experience I got with it and the better I got at doing it, the more I realized how difficult and how many layers there were to it. You know what I mean? Mm-hmm. And there's a really great book called Thanks for the Feedback, which talks about how there are inherent barriers to giving and receiving feedback. And especially, when you're in an academic setting, the hierarchy is set. You have your instructors and you have your students, right? So the students are ready to take information from the instructors. That's how the hierarchy is. But in the real world, that's not the way that it works. Like, people, I'll be honest, most patients that I see don't give a shit about my degrees. They don't even know what they mean. Yeah. They're one of the main reasons why I stay active in the gym is because, and you probably appreciate this as a coach, how many of your clients would leave you if you could only bench press 135 pounds?
Yeah, there'd be a decent amount.
Yeah, like why would I listen to this guy? Because he obviously doesn't know what he's talking about. It doesn't matter how many degrees you have, right?
Yeah.
So I've realized as a clinician, like, hey, I spent all this time learning more, getting better and better, but the patients that I'm actually serving don't care about that. They care about how much I want to go to see a clinician that understands powerlifting. I want to go to see a clinician that understands weightlifting, that does it themselves, that's decently strong themselves, right? So there's so many levels and factors to all that. It's like I said, it's one of those things that as you learn more about it and as you get more experience teaching others, there's just like all these other things now you have to think about, right?
Yeah, it's the epitome of a Dunning-Kruger.
Yeah, 100%. Yeah, you've fallen off that Dunning-Kruger cliff.
You are way down, way down the I don't know anything route.
Exactly.
Yeah, it's really funny when you talk about the integration in an academic setting, right? Where it's like you have your you have your supervisors, right, your faculty members, your tenure track people, and then you have your postdocs, and then you have your students, and then like master students and undergrads, and everything like that. And one of the funniest things that I've always heard, at least at A&M within our lab, is you're ready to finish your PhD when you're finally disagreeing with your faculty, with your mentor.
Yeah,
when you're finally pushing back and saying like, what the hell? That is not how that works. Like, what are you talking about, dude? No, this is how this works.
And what you just said is exactly that filter. That's that critical. That's the second layer of that. Like, hey, you've gotten this information, right? You've gotten this feedback, but actually I know enough now to start asking some questions, and maybe I'm not going to integrate that because I think it's something. And what you just described is kind of the point that we want all of our patients to get to as well, where it's like, hey, I'm teaching you along the way, and if something doesn't make sense to you, right? If I want you to take an actionable step on it, you need to own it. You need to understand it, which means there needs to be a little bit of pushback there, right? We need to have, maybe they still don't understand the full context of whatever, but that filter part needs to happen. So ironically, you kind of just connected the dots to both of those last two topics we talked about.
Yeah, no, dude, and I think that's a really, really good example and a great point to bring up because I experienced that in the powerlifting world. I educate my clients. I think, one of the core tenets of Escalate is education, strength, education, and community.
Right.
That is what I am built on. Is what I'm trying to build this company to be. And when you educate, you also have to drop that ego.
100%.
And it's like you said, you want your clients, you want the people that you are educating to come back and challenge you.
Yep.
Because if they do, that means that you've done a good job. And I think it's extremely important on the ego side of things to drop that ego because the feedback that they're giving you, the pushback that they have, like say that I have a client and he's doing really, really well. And then I tweak his program, week to week or block to block. And all of a sudden he's not feeling super strong. And, I can't really see those changes, right? But he may go back and, maybe I'll go back to and I'll look at, what we've changed over the past couple blocks. And he'll come up to me and he'll be like, hey man, what is going on? Like, I don't feel strong. I think this, and this is why I need, or what I need to start feeling stronger. And as a coach, you have to drop that ego and be like, you know what? I think you're probably right.
You're paying me. Why are you telling me what to do, right?
Yeah, exactly. And I think it's an extremely important thing to understand because for a client or for a patient, that is their only reaction, right? You are their only coach. For the practitioner, for the coach, they are one of 30 to, as a clinician, hundreds of people that you work with within a year. Right? And that, allocated attention, you might, automatically just think if you have a big ego, like, they don't know what they're talking about. They're not a coach, da-da-da. They're thinking about their own training every day.
Yep.
They know what works for them.
Yep.
And so when they do challenge you, understand like, oh no, this is good because I've educated them enough to get to this point where we can find solutions extremely quick.
Yep. And I think, I always say, ego is the enemy, right? The ego, we want to tell ourselves that we're the experts, we have all the answers, and we can help everybody. And if it doesn't help them, that's because they're stupid and they messed up, right? Yep. And the reality is that if you want your client to follow the program and to do what they need to do to get better, to get stronger, whatever, they will follow that a lot more strictly if they own it.
Yep.
And the only way to own it is to be integrated into some of the decision making, right? I may know that, hey, if, let's just use a contrived example, hey, doing some dry needling would help your pain right now. But if they don't feel that way, or they disagree, or they don't understand, or whatever the case may be, it's going to be very difficult to get the same results that we would want, because they have some doubts, they have some questions, they have some pushback. Same thing with following a program. If they're going to really follow it and own it, and it has to own it, it has to be theirs. And the best way to facilitate that process is to say, hey, look, here's what I think based off the information that I have. This is what I think you should be doing. What do you think about that? Do you have any, because again, they're with themselves 24/7, right? You're talking to them, a couple times a week or whatever the case may be, right? So if they can say, oh yeah, I agree, or oh, actually I disagree, and even better, that's what that book, Thanks for the Feedback, comes in, is you just know that if you're a coach and you have a client, there are a lot of people that will disagree and not tell you. So that means that you're telling them to do something, they don't think it makes sense, they don't want to do it, they're not going to say it, and then they will either do it and begrudgingly do it, or they will not do it and not tell you. And that means that there is a divide in information. You're thinking that they're doing X, Y, Z, and then you're planning accordingly for that, but there's missing information there, right? Versus if you sit down with them at the very beginning, you say, hey, look, my role here is to help make you as strong and healthy as possible. This is kind of the process that I'm going to go about doing that. One of the most important things is that you provide feedback, you ask questions. If something doesn't make sense to you, you let me know, and then we can talk about it and get on the same page. If you set that precedent at the beginning, and then when they do bring up feedback and so on, you're receptive and you integrate, the relationship gets a lot stronger. They feel more confident in the program. They're learning more. They take ownership of it, which means they're executing on what they're supposed to be doing. And if they don't, they let you know. They feel comfortable letting you know, hey, I didn't have time, or I skipped out on this, or I went up this weight instead, right? And then everybody wins, right? They're going to stay with that coach way longer, because I guarantee you when you go to other coaches, that's not going to be the way that it works most of the time. And it's the same thing with clinicians. I hear all the time from patients, they go to see a clinician, they tell them what they're doing, they kind of had some questions, or they've maybe even brought up some concerns, they were dismissed, they weren't listened to, and then that puts up this huge divide between the clinician and the patient. And we talked about at the beginning, that therapeutic alliance. What's crazy about the power of that is when you look at the research, if we take evidence-based care, let's take patellar tendinopathy, right? A classic injury. If we take a group of people and we provide evidence-based care in a silo, meaning we are giving this person exactly the right exercises to help improve that patellar tendinopathy, but the person giving that information to them, they don't know, or they don't like, or they don't have a good relationship with, we have that group, and we have another group that the patient and the therapist, they get along really well, they like each other, they communicate well, they have a good relationship, and that therapist gives them like ultrasound on their knee. Which of those two groups are going to get better? It's the strong therapeutic alliance group, meaning that we spend all this time talking about what's the best intervention, what does the research say, what is all this, we get better skills, we get better diagnostics, we get better and better and better and better at that. But we're missing out on all the social communication, all of the trust building. And that is the strongest predictor for success from any injury. And if you look at our healthcare model, technology is getting better. We're able to do surgeries and interventions that would have been hospital stays a decade ago, and now they're outpatient simple procedures. Not only is this hospital stay getting less and less severe, complications from surgery are getting less severe, all that is getting better and better and better. And when you look at our outcomes across the board in almost all of those types of injuries and those treatments, we're getting worse the outcomes are getting worse. And when I see technology improving, us getting more efficient, all that getting better, and outcomes getting worse, what I think is we've taken out the like health part of healthcare. Like there's no emphasis on building a relationship with your physician or your PT or whoever, and the focus is solely on getting you the whatever the XYZ treatment is for this person as fast as possible, right? It's like you go to the doctor's office and you wait for 45 minutes for them to talk to you for 2, and they give you this XYZ treatment that you don't even understand. You haven't had a chance to ask questions. There's no trust or relationship there. And what the long-term effects of that is that people don't get better, right? Yeah. So it's like if you're in a coaching business, you're really in a people business. If you're in providing patient care, you're in a people business. And you should spend just as much time, if not more time, focusing on communication, building rapport, giving feedback, education, all that stuff as you do your skill set, right? But think about how many education classes or how many CCUs, how much training do you go through to get better at progressive overload and different variabilities. You get training on all that stuff, and nobody even talks about the communication part. But that is probably the biggest predictor to success.
No, 100%. I agree, and I thank you for having this conversation with me, man. This was a great talk. Mm-hmm. I'm going to give you a second to plug anything. So if you of course you have online CCUs available, stuff like that. Ignite, I think, is the company that you do that through. Yep. You want to plug that, plug Rise, anything like that.
Yeah, so obviously if you're in the North Houston area and you need a gym, Rise, we've got you there. We do powerlifting and strongman and group classes and pretty much everything. We're about to expand to 35,000 square feet here pretty soon, so pretty large facility. So definitely would love to have anybody interested in doing that stuff. From an education side, I own a company called Ignite Clinical Institute. So we do CCUs for PTs and also like personal trainers, strength coaching. We have a bunch of stuff on pain. We actually have a communication online course that we do that's great for those soft skills. So we've regularly had like coaches and personal trainers and stuff join, although some of the material is geared more towards physical therapists. But yeah, would love to have anybody out there. And also too, my email, which I guess I can just say it out loud, but maybe you can put it on there.
Yeah,
but
I'll link everything down in the bio.
So if anybody has any questions or, are not sure where to get started or whatever, or obviously if you're a patient that needs help, let me know. I'm more than happy to answer questions, or even like, how we started talking was just like through Instagram, just talking about stuff. Always down to do that. I think like collaboration is probably the single most fruitful thing to my own education, just trying to make sure that I'm staying on top of stuff and, continuing to sharpen that knife, so to speak. So.
Yeah, and like I said, I'll include all of those links in the description of whatever platform you're listening to this on. Yeah. Whether it's YouTube, Apple Music, or Spotify. But if you got this far, it's been about an hour. If you got this far, thank you. We appreciate you listening to us ramble for a bit. Yeah. And thank you again, Sean. This is amazing.
Appreciate you having me on.